ladies and gentlemen. It's a privilege to present an RA Asia 2025. Today, I want to address a fundamental challenge in our practice, knee stability, especially how we can restore it using Dextrose Prolotherapy. Over the next 20 minutes, we will move beyond the idea of simple pain relief. We are going to explore the latest clinical evidence and the biomechanics that prove prolotherapy is a structured intervention. We will look at how this treatment works from the molecular level up to clinical application. By the end of my talk, I hope to offer you a new perspective on treating the unstable knee. Okay, again, my name is Wei-Chen Liao. I am a physiatrist and pain physician based in Taizhou, Taiwan. My specialized field is ultrasound-guided regenerative medicine. Let's start with the patient we know very too well. They walk into your clinic and complain of chronic knee pain. You do your best and you see their MRI. However, the MRI report always says mild or the normal. But the patient insists, "Doctor, my knee is so pain. It's too loose. It hurts every time I take a step." This is why I call that the invisible instability, also called micro instability. The ligament was loose enough to cause abnormal movement and destroy cartilage, yet not torn enough for the surgery. This leaves us with a massive treatment gap. We have a painkiller on the one side and the surgery on the other side. What do we offer in the middle? To answer that, we also can think about the paradigm shift from suppression to regeneration. For decades, the standard medical model has been to suppress inflammation. We use corticosteroids and we use NSAIDs. However, we know that inflammation is a body's natural signal to heal. Why are we stopping it? Regenerative medicine, and especially prolotherapy, flip this model upside down. We do not rock the fire, but we also control fire to restart the healing process. And importantly, for this conference on applied anatomy, we are shifting our focus. We are stopping the obsession with the joint space and moving our attention to the athletic organ, that critical interface with soft tissue anchored to hard bone. So when we say stability, what do we really mean? I propose we view it as a three pillars framework. The first, there is a passive stability. It's like a ligaments, capsule, and fasces, and those are attached on the hard bone. The second pillar is a proprioceptive stability. It's like a software, the nerves and the sensors that tell the brain where my knee is. The third pillar is a dynamic stability. This is the motor, the muscles that react to protect our knee. My main message today is this. Dextrose Prolotherapy is unique because it restores all three pillars simultaneously. So, how does simple sugar water achieve this? It starts with molecular mechanism. When we inject hypertonic dextrose, which is 50 to 25%, it creates an osmotic shock. And this stress signal to the local cells to wake up. They release a cascade of key growth factors like PDGF or TGF-beta. Furthermore, recent research from 2025 this year suggests it moderates the neurogenic moderation. It acts on specific ion channel on the nerves like TRPV1. It creates a transient release of substance P that acts like a reset button for the tissue, switching the environment from chronic degeneration to active repair. Let's look at the first pillar, the hardware. Injured ligaments often develop a scar phenotype. The fibers are thin, weak, and disorganized. I want to highlight the pivotal animal study by Jensen from 2008. They treated injured ligament with dextrose. Their results were striking. The collagen fiber didn't just swell, they actually recovered their size. We saw that they are much recovery of large diameter fibrils and increased fibril density. The tissue became more organized. This proves we are changing the physical structure, not just the symptoms. These slides connect directly to our applied anatomy today. The emphasis is not just a connection point. It's a complex organ with 4 distinct zones. Zone 1 is a soft tissue, transitioning all to the zone 4, which is hard bone. Chronic knee pain often comes from a breakdown in those transition zones. Prolotherapy works by stimulating repair across all 4 zones. It helps re-establish the tight mark, the barrier between the soft and the hard bone. Biologically, they're regluing the ligaments back onto the bone, ensuring the anchor is fixed. This brings us to the concept of biotensegrity. The body is a continuous web of tension. When prolotherapy tightened the extracellular matrix ECM, the cells inside that matrix physically feel the increased tension. This is called mechanotransduction. Because the matrix is tighter, so the cells receive a signal to produce even more collagen to handle the load. It creates a positive feedback loop. A stiffer ligament makes the cell work harder to maintain stability. By treating the ligaments, we restore the tension integrity of the entire lower limb. So now let's discuss the second pillar, the nerves. Ligament elasticity is not just a mechanical failure, it's a neural failure. We call this deafferentation, or called loss of sensory input. Ligaments are filled with sensors, mechanoreceptors. When the ligament is loose, their sensors start firing. The brain loses its GPS signal from the knee. So that explains why patients often complain that their knee feels like it's giving way or buckling, even if their muscles are very strong. The brain simply doesn't know where their knee is. Here is the exciting part. Prolotherapy helps nerves heal. The injection stimulates VEGF, which brings in new blood supply, and nerve growth factor NGF, which promotes reinnervation. Clinically, we often see patients who say, "Doctor, my knee feels steady," or only a few weeks after starting treatment, long before new collagen has fully matured. Why? Because we have rebooted the neural feedback loop. The sensors firing again. The brain can see their needs again, providing an immediate sense of stability. This leads to the third pillar, the muscles. When the knee is unstable, the muscles react poorly. A phenomenon, they fire too late or they contract at all once, a phenomenon called co-contraction. This frees the joint and massively increases pressure on the cartilage. By fixing the sensors in the ligaments, prolotherapy restores the normal reflex arc. It allows the muscles to fire in the correct sequence, known as feed-forward control. We are essentially updating the driver on the car so the ride becomes smooth again. Furthermore, muscles cannot work without a solid anchor. Imagine trying to pull a heavy object with a rope that is tied to the loose stake and in the sand. It doesn't work. Oops. The muscle force is wasted. The Jensen study we previously mentioned before showed that dextrose-treated ligaments had 30 to 50% higher pull-out strength. This means the attachment to the bone is much stronger. When the muscle contracts, that force is effectively transferred to the skeleton. Stronger ligaments actually make the muscles more efficient. So far, we have discussed theory and animal models. Let's look at the human control trials for clinical proof. The KT-1000 is a specialized device used by surgeons. It is the gold standard of objectively measuring how loose an ACL is. It measures the displacement of the tibia in millimeters. Dr. Reed and Hassanin conducted a landmark randomized control trial. They took patients with confirmed ACL elasticity and treat them with dextrose injections. This study provides some of our strongest objective data. Please look closely on this data. This is the game changer. After 3 years of follow-up, the patient who received prolotherapy showed a 71% improvement in ligament tightness as measured by the machine. Even more impressive, 10 out of 13 knees returned to a completely normal range of motion. This is not subject and not a placebo. This is objective mechanical evidence that dextrose prolotherapy can physically tighten a loose ACL without a scalpel. Is this evidence out of date? Absolutely not. System reviews published just this year and last year in 2024 and 2025 continue to support these findings. The data show that prolotherapy provides functional improvements superior to exercise alone. And when compared to corticosteroids, the pain relief from prolotherapy lasts much longer. While it is comparable to PRP in some aspects, prolotherapy remains the premier choice for addressing the specific issue of ligament elasticity and stability. We can also see this change with our own eyes using ultrasound. Before treatment, a damaged ligament often looks dark, hypoechoic, swollen, disorganized fibers. However, after a course of prolotherapy, the tissue transforms. It becomes bright, compact, and dense, and even organized. We can also perform a dynamic stress test under ultrasound. We physically see that the joint gap opens less than before. The visual evidence perfectly matches the clinical improvement. So, how do we apply this in our clinic? My advice is, don't just treat a single spot that hurts. Use the shotgun approach. Knee stability relies on the network. We mentioned about the biotensegrity before, right? You must treat the medial compress, the lateral compress, the anterior structure, and even posterior structures. You treat the whole functional unit. If you only treat one loose screw, the machine will stop settle. So you need to tighten the whole frame. Regarding the solution, precision matters. For intra-articular injection inside the joint capsule, I recommend a higher concentration around 20 to 25% dextrose. We need this high osmolality to trigger the synovial cells. For extra-articular injection at the anthesis, I use 50%, or someone use 12.5, okay? And this concentration is a sweet spot. It is strong enough to stimulate the fibroblast to repair the bone ligament interface. But it is less painful for the patient than higher concentration. The safety profile is very good, especially when compared to the corticosteroids. Finally, we cannot ignore rehabilitation. There is a principle called Davis' law, which states that soft tissue models along lines of stress. After the initial treatment and initial inflammation settles, usually after 3 to 5 days, the patient must move. We need them to do controlled exercise. This mechanical law tells the new collagen fibers which way to align. The combination of prolotherapy plus exercise is statistically superior to either treatment alone. So, in conclusion, Dextrose Prolotherapy is a comprehensive structural intervention. It restores tacit stability by rebuilding the collagen. It restores proprioceptive ability by healing the nerves. And it restores dynamic stability by optimizing muscle control. We have the histology, biomechanics, and the clinical trial to back this up. I invite you to evaluate stability in every knee pain patient you see. It is often the missing piece in the puzzle. Thank you very much for your attention. This is my email link, and this is my mentor, Dr. David Wang. And I also introduce my next speaker. Before Daniel says, the next speaker is my good friend, David. Here is a photo from our last meeting in Cancun, Mexico. And this is a photo from the workshop the day before yesterday. Okay, thank you very much.
I probably have a little bit more gray hair from one.
Okay, thank you, Dr. Liao, for your wonderful presentation. What a concise and precise presentation. I really love it. And our next speaker is Dr. David Wang. I believe some of you might have